Okay, so this is a patient with abdominal pain, and I want the residents to tell me what they see. Oops, I need to take off these. Well, anyway, let's see. Okay. So one of the residents, can you describe what you're seeing, what's on your differential?
All right, so we have CT abdomen with contrast, and at the level of the stomach, we have this large heterogeneous mass.
Good. So, and I realize I'm scrolling instead, but the stomach is here.
Oh,
and
I see.
Here.
So it's, wait,
Oh, it's under the stomach.
so it's
Pancreas.
And then the good thinking. So the pancreas is here. So we're still maintaining
Yeah, there.
that plane with the pancreas.
so it's
I guess.
Yeah, it looks like the duodenum, jejunum, and then this mass is kind of affiliated with those bowel loops, the proximal jejunal loops. So what do you think about it?
it could be probably metastasis or just what it, I
From
mean,
what?
breast.
Okay, breast can metastasize to the small bowel, and then you said, I heard you say gist, which is
Yeah.
a good thought, because gist can kind of get ulcerated and have air
Yeah.
within them. They can get centrally necrotic.
Uh,
Gists are usually endo or exophytic, but it's hard to tell here. I think gist is very reasonable. What else?
I think lymphoma also.
Excellent. So I would have thought lymphoma near the top, because lymphoma likes to thicken the bowel wall and cause aneurysmal dilation without obstructing the bowel. So this is a really good look for lymphoma. But lymphoma, usually you might see other lymph nodes around in the retroperitoneum, like it's not usually just isolated to the small bowel. Anything else?
And
Coronal.
yeah, I don't know if it's coming from the adrenal now.
No, it's too anterior.
This can be an endocrine tumor.
Okay. Neuroendocrine can be anywhere in the GI tract. That's an excellent thought. Usually when they're in the small intestine, they are small, little, tiny multifocal tumors in the small intestine with like a nodal metastasis. Most commonly, the primary tumors in the ileum, appendix, or rectum. So jejunal neuroendocrine is more rare, but good, excellent. There's one more thing you did not mention.
Mm.
So just an adenocarcinoma. And actually that's what this turned out to be. Yeah.
That is true.
So this is just a small bowel adenocarcinoma. It is a little atypical. Usually they are apple core lesions that cause like upstream obstruction. And they are overall rare, much rarer than colon cancer, but they can be very aggressive. This was a moderately differentiated adenocarcinoma. So I was kind of betting my money on lymphoma in this case, because it's so big, but it's not causing obstruction. So it's more like a soft tumor, but this was biopsied and then eventually resected, and this was an adenocarcinoma. So, and I'll just show you, we did do an MRI. It didn't really add much. I think MRI in this situation can help look for mets, like especially like liver mets, but I'll just show you what it looked like on MRI. So it was actually pretty T2 bright, maybe even there's like a mucinous component to it. But I don't think the MRI is very specific. On the pre-contrast, it's intermediate. Arterial phase, it's kind of lowly enhancing, and then on the delayed phase, it had more progressive enhancement. But none of that is really specific. That could have been for a gist, it could have been for lymphoma. So anyway, just don't forget about adenocarcinoma. But great differential, good job.
So this is a cute one. And again, I'm going to encourage the residents to keep an eye as I scroll through. And then once I finish, tell me what you see. I won't provide any history right now. And then I'm going to show you the coronal as well. Here we go. Anything that catches your eyes?
Kidneys?
Both of the kidneys,
Oh, it could be the one that goes. this way.
semi-horseshoe, they're both ptotic. That's
Yeah.
like in the pelvis. Oh, they are communicating? Yeah.
Okay, so what is your consensus? Is this a horseshoe? Is this an ectopic? And I'm going to show you the region of the native kidneys.
Because they look like they communicated.
What about
Look,
the
look at she's showing you the region of the native
native
kidneys.
kidneys? Look at the retroperitoneum and where the native kidneys should be.
Yeah.
So they're very atrophic and small calcified.
Exactly. So this is an older patient and they have renal compromise because of lithium, long-term use of lithium. So the native kidneys are still there. They are severely atrophic. You're absolutely right.
Wait, I have a question for the residents.
Yes.
So if there's 2 kidneys in the renal fossa that are atrophic, and then there's 2 kidneys in the pelvis, is it possible to have 4 kidneys?
I don't think it's very normal to transplant multiple and natively have them. No, I would say not.
Okay, so to answer your question, 1, it is possible to have 4 kidneys. It's called supernumerary kidneys. Your kidneys actually develop as 2 buds on each side, and then they fuse and then ascend into the upper abdomen. So it is possible to actually have 4 kidneys. And I have a case where I had 3 kidneys. But like you said, this is not a case of supernumerary kidneys, I think. Anu, you can correct me if I'm wrong. But and then you also said it's not normal to transplant 2 kidneys. So but there is a situation in which you will get 2 kidneys transplanted.
Yes, and that is the point of showing this case precisely. So you see some surgical clips and, so that kind of indirectly points you to the direction that these are probably transplant kidneys. So indeed, in this adult patient, there are 2 transplant kidneys in the right iliac fossa. Normally, when you see multiple transplant kidneys, one of them is non-functioning and a new one is transplanted because the one that they did earlier had failed. But here, both these kidneys look like they are beautifully enhancing, they're pristine, and it suggests indirectly that both might be functioning very well. So this is a situation where this is called dual kidney transplant, not single kidney transplant. And interestingly, there is a cohort of patients where they do 2 kidneys, either 2 adult kidneys or 2 pediatric kidneys that they might transplant simultaneously in a patient. And why might one do this? So basically, you need enough nephron mass, which is a predictor of long-term graft outcome. And in the transplant world, there is a concept called nephron dose concept. What basically, in simple words, it means that there needs to be adequate mass of nephrons for the transplant graft to work well. Now, in order to expand the cohort of donors, what people have tried experimenting and what has worked well is they have expanded the criteria for in patients in which they can harvest these kidneys. And so it's called expanded criteria for donors. And some of the criteria include deceased donors that are over 60 years of age or donors who were 50 to 59 and had 2 of the following: either donor history of hypertension, donor death due to CVA, stroke, or their terminal serum creat value greater than 1.5 milligrams per deciliter. Basically, that means that their renal function was compromised in some way, but not severely. And so these can, under the expanded criteria for donors, donate their kidneys to patients. The other interesting point, and in this particular patient, these 2 kidneys are pediatric kidneys. So there is a paper which has shown that if a pediatric donor kidney is harvested, if the child is more than 2 years of age, 2 to 15 years of age, then a single kidney is sufficient for long-term optimal functioning. But if the child, unfortunately, is less than 24 months, then they usually tend to harvest both the pediatric kidneys and place, particularly when they want to donate it to an adult patient. So that is the story here. These are pediatric kidneys. They were simultaneously transplanted into the right lower quadrant, and they're working just fine. Any questions?
Anu, that is a great explanation. I did not know that they do it with adults with that expanded criteria. So that was really helpful. And actually that makes a lot of sense. It's kind of like, you know, the expanded criteria for liver transplants. Like now, if patients are willing to accept a liver that has Hep C or HIV, that it, you know, doesn't necessarily have cirrhosis yet, then it can reach, transplants can reach more patients. So
Agree. I thought it was super interesting. All
One,
right.
one more point about the pediatric kidney thing is, can you scroll through? So often they will take both kidneys and the renal vessels and the aorta, and sew the pediatric aorta to the adult's external iliac vessel, because so it's kind of nice because you have like an automatic, like a natural anastomosis between the two kidneys.
Yeah. So here you can see it actually.
Yeah.
Okay. Excellent. All right, let me stop sharing.
So this is a patient with pelvic pain. Their uterus was pretty normal. And then this was the region of the right ovary or right adnexa. So we've got a large mass-like lesion, but it did not seem to have flow within it. Pretty heterogeneous, but also kind of, you know, internally has a lot of low-level echoes. So that's the right side. And then on the left side, sorry, I'm gonna just fast. Okay, so we still have our big lesion on the right side. And then we also have some kind of lesions on the left side too, that we're kind of seeing in the left ovary here. So residents, what would you do at this point? You see bilateral lesions that look like this.
Probably a pelvic MR.
Okay, and what are you thinking this could be?
I'm concerned that maybe like a dermoid or no, it just doesn't look happy.
Okay, good. So, and especially this big lesion, okay, you're thinking dermoid, but some of the features of dermoid we don't really see here. So some, like in dermoid, sometimes you might see hair. So you might see like dashes of echogenicity. You might see a tooth with shadowing behind it. You might see the tip of the iceberg sign where you have like a really dense plug at the top and then a lot of shadowing behind it. Or it might just be really bright because of a lot of fat. So some of those classic features of dermoid I'm not actually seeing in this lesion. And when you find out what this lesion is, you might say like, oh yeah, that makes sense in that space. Okay, so now moving on to the MR. Okay, so here's our big lesion here. Our other ovary, the left side, has a bunch of follicles, but also additional lesions here. Okay, and then I'm going to show you the pre-contrast. So this is the T1 pre-contrast. Sorry, there's a lot of things that keep showing up. But anyway, that's our big lesion, T1 pre-contrast, additional ones on the right and on the left, really T1 bright. So now what are you thinking?
Could it be an endometrioma?
Yes, excellent. So anytime you see multiple very T1 bright lesions, think endometriosis. And that's what this was. So multifocal endometriosis in both ovaries, including this very large endometrioma here. Another cool, interesting thing is that there was deep infiltrating endometriosis. So you can see that the rectum is being puckered here by this deep infiltrating endometriosis that's extending in the rectovaginal space. So all of this tissue between the uterus and the rectum should not be here. All of this right here and pulling on the rectum right here. So that's deep infiltrating endometriosis. And then the case gets even cooler because in the pelvis, there was also some weird enhancing tissue here. In the right lower quadrant on the cecum, but also extending into the abdominal wall. And then gets even cooler because as we get to the liver dome, we can actually see that there's lesions here. I'll show you in a minute that they're enhancing, but at the like high liver dome, there's actually all these T1 bright lesions. So what do you think these T1 bright lesions are, or even these lesions enhancing along the liver surface?
Are they just more deposits of endometrium?
Yes, yes, exactly. So this is all endometriosis, and it actually makes sense. This is a really nice example of like the multiple different patterns and distribution of endometriosis. So we had those endometriomas in the ovaries. We also had spread to the right lower quadrant, and that's a kind of classic location to go onto the appendix or cecal area, and then also up into the liver. And the reason why is that you have a peritoneal cycle that basically pushes your peritoneal fluid in a certain direction, which goes along the right pericolic gutter and then up between your liver and your diaphragm. So that's why if you get endometriosis deposits at, in your lungs, it's usually at your right lung base, because those deposits get pushed up between the liver and the diaphragm, and then they travel through fenestrations in the diaphragm to the right lung base. Whereas on the left side, the splenocholic ligament actually protects the diaphragm on the left side. So because of this, like the direction of the cycle, it tends to push things into the right upper quadrant. And this stuff here, this enhancing stuff that's like on the liver capsule and kind of almost going into the liver, is the deep infiltrating endometriosis, like invading into the liver here. So this is at risk for traveling into the pleural space and becoming, causing a pneumothorax, these deposits along the liver edge. But just a really nice example from one of my colleagues of, just how extensive it can be, and can go often up the right side.
Aarti, really cool case. Can I add one small thing on that ultrasound image?
Yeah.
There was a nice finding there. When you were
Okay, let me
describing-
pull it back up. I
Okay.
just don't want to.
Sounds good. Yeah.
Okay. Yeah, one more thing that we talked about when we were showing this case in our group was, is it okay to have all this enhancement in endometriosis? And I would say, especially when you have deep infiltrating endometriosis, it can incite a lot of fibrosis. And so it's often just fibrosis from that. It's not malignant transformation. We also often see that in scar endometriomas. So when it's that fibrotic reaction, that's usually just fibrosis. But if you have an endometrioma in your ovary or adjacent to your ovary, you're going to want to look for any solid components, because they can have malignant degeneration, usually into endometrioid cancer, but also into clear cell carcinoma. Okay, I'm going to pull up the ultrasound.
With the large
On the
endometrioma.
transvag.
Yes, right there. Yeah.
Okay.
So, you were describing how the various features of dermoids one can see with echogenic areas, the whole thing may be echogenic and shadowing. So one feature that is described in endometriomas is echogenic nodular deposits or nodular tissue along the walls, like we see here. And literature describes these as cholesterol crystals, giving rise to those echogenic nodules within an endometrioma. I don't have.
Oh, wow. Cool. I've only like the classic ones that I've seen, I always describe them as like homogeneous low level echoes, which I feel like in between there are, but I did not know what these echogenic areas were.
Yeah. We see them, I'm seeing them floating in the middle for the first time, but I've seen multiple where these are nodular and along the wall. And whenever I've tried to look for an explanation, I've seen multiple areas where they say these are cholesterol deposits, which can look echogenic along the walls. So just a cool fact. And they don't show any Doppler and signal within them. There's no vascularity within them. And that's how you distinguish them from malignancy developing in an endometrioma. And of course, if there is malignancy developing in an endometrioma, this ground glass-like appearance will be replaced by anechoic fluid because of hypersecretion of fluid from the malignant nodules into the endometrioma. And that also contributes to decrease in T2 shading within endometriomas when there is malignant transformation. So just some additional facts. Yeah.
I do find them to be tricky when you're on the spectrum of possible malignant degeneration, because we've had several now where there's like enhancing components to an endometrioma. And then the final path comes back as like benign with fibrosis.
Yes.
So it seems like it's a little tricky. We're not totally specific even with MRI,
Yeah.
but you always have to bring it up if you see an enhancing nodule.
Completely agree. Yeah, we had one where they reported polypoid endometriosis on pathology for those enhancing nodules, and one they just said endometriosis. There was no explanation of that.
The enhancing stuff. Yeah.
Yeah. All right, this one again is for you guys, and I'm going to scroll through, not an eye test, but look at all the findings and tell me what you think. I'm going to go slow. This is a woman. So these are axials, and I'm going to run through the coronals as well. Again, not an eye test, but think about what these might be, what might the primary be, where might the primary be. All right, go for it.
It's like ovarian in origin because it looks like it's a thick-walled, enhancing septate.
Excellent.
It makes me think of like a mucinous cisadena.
Okay, excellent. On the right track. These are seen on both sides. So what do you think of that? So you're thinking correct. These look like they're ovarian. They could be mucinous. And if you see these involving both the ovaries.
Yeah, it's like a GI primary with metastatic disease to the ovaries.
Okay, excellent. You're absolutely on the right track. So yes, these were mucinous metastases to both ovaries, but the primary was a little surprising. So I'm going to go back slowly and show you the region of the pancreas. So you see this small cystic mass in the pancreatic tail, and there is some upstream dilation as well to prove that it is within the pancreatic parenchyma. So it turned out that this was a pancreatic adenocarcinoma, mucinous subtype, and this was the reason giving rise to large mucinous metastases to the ovaries. So, you know, usually we think in our minds that mets are smaller and the primaries are larger, but that's not always the case. And pancreaticobiliary tumors with mucinous morphology that metastasize to the ovary, they are not common, but they are said to account for almost 14% of metastatic mucinous tumors to the ovary. And Aarti, feel free to add any additional points.
Yeah, this is a great example of like how the ovarian Krukenberg tumors can be massive compared to the primary. I do have some questions. So whenever I see possible Krukenberg or like, you know, ovarian masses bilateral, I always look at the stomach and the pancreas first. Sometimes also the appendix, colon, especially if you're like looking for a mucinous primary. Appendix loves that. But this pancreas one, when you said pancreatic adeno with mucinous subtype, I'm just kind of curious, were they able to distinguish like if this was an adeno with mucinous features or this was like an MCN that just went really bad, like an MCN with adenocarcinoma developing in it? So like, was there ovarian stroma on the wall? So they were able to say this arose from an MCN.
Yeah, so I'll read you the exact path. The tumor involves ovarian stroma and has an intestinal phenotype with focal mucin production and necrosis. So interpreting
it sounds
this,
like an MCN then.
Yes, exactly.
Really bad. Yeah,
That
but
was
it's
my
amazing it's that small. You don't have an MR, huh?
I'm
going to withhold a little bit of history, but you can see that there's bilateral adrenal masses. That are pretty T2 dark. And then coming down, it's like there's additional masses along the obturator chain and the inguinal canal that are pretty T2 dark. I will show you some This is post-contrast, post-venous phase. They're very bright. What's the next sequence you want me to show you? President?
Do we have any chemical shift sequences?
Yep. Let's see. So in phase, I'll just show you these adrenal ones. Out of phase here. So, oh, sorry, yeah. They are not really dropping in either one. So they don't have intravoxel fat, so these are not adenomas. And also they are not dropping on the in phase. So it doesn't seem like that it's just like iron, hemosiderin, metal, or air. But they are very T2 dark. Is there any other sequence you want me to show you?
Is there a diffusion weighted?
Yep. But I mean, it's kind of a trick question because you would have looked at the sequence. But what I wanted you to say is the pre-contrast. So this is the pre-T1. I showed you the venous phase and they looked really bright, but now I'm going to show you the pre, and you can see that they're also really bright here. There's lots of little bright stuff all over the place. So what do you guys think?
Melanoma.
Good. So this is kind of almost a little bit reminiscent of that endometriosis case, right? Like super multifocal T1 bright, but really weird distribution for endometriosis. This, adrenal glands, that would be very weird, although not impossible. You do have a little bit along the liver. So, if this was a female, maybe thinking endometriosis. And then these are all in a lymph node distribution, which would not be typical for endometriosis. So this was metastatic melanoma, and these were melanocytic. So they're really, really T1 bright. So melanoma mets are not always T1 bright, but when they are, it's a really nice, kind of clinches the diagnosis. Yeah. And then actually, let me show you the subtractions because, to see if there's true. Oh, wait. Okay. Going back up through the adrenals. Yeah, so there's not a lot of enhancement here. So most of it is just the melanin, the really T1 bright melanin. And just for fun, we're going to show the diffusion. So this is not that bright, but there are foci areas where it's bright. Yeah, I don't think it really helped. But anyway, this was metastatic melanoma. Okay, so I'm scrolling through and you can let me know if you have any observations. I think the main findings, let's see if there's anything else down here. No, the main findings are in the area of the kidneys and here in the upper abdomen. So we can see that there's this kind of homogeneous mass here in the retroperitoneum. There's all this kind of haziness in the perirenal fat. So you can see that there's a lot of perirenal fat. Some people just have that. You can see it's pushing, the retroperitoneum is pushing the rest of the abdomen forward here with all this proliferation of fat. But there's also like soft tissue in the renal hilum here. So what's your differential for like soft tissue that's predominant in the perinephric space, but maybe also associated with other soft tissue, paraspinal soft tissue masses?
Retroperitoneal liposarcoma.
Okay, so you're thinking about a liposarcoma. Good. I will say it's usually not bilateral. It often starts in one side. It could have smudgy soft tissue in it, but usually it's kind of like a more encapsulated mass with both fat and soft tissue, usually starts on one side and kind of pushes everything forward. This is more infiltrating the entire kind of space here and is bilateral. Anything else?
Can they phone a friend?
Sure, Anu, yeah, tell me.
Lymphoma, because it's so multifocal.
Yeah, good thought.
IgG4 disease is possible in the retroperitoneum like this, but it's a little unusual presentation.
Right, and IgG4 is
typically-
usually more fibrotic, so it might
Yes.
cause hydronephrosis, which it's not here.
Yeah.
And then other things we think about with pararenal soft tissue is like Erdheim-Chester, extramedullary hematopoiesis. Yeah. So anyway, and with this paraspinal soft tissue, this turned out to be extramedullary hematopoiesis. So it loves the pararenal space, but it also loves the paraspinal areas. All of these things would be in the differential. For extramedullary hematopoiesis, you always look for, is there a reason that their bone marrow is fibrotic or failing and that they need to like have these, the activation of the extramedullary myeloproliferative cells. So yeah, that was it.